With that, I'm going to finish up, and I'm going to invite two of the young women that I've been sponsoring in the last little while to come to the stage and talk about the next steps in all of this. Dr. Kelly Barrett is an intensivist trained here, and for those of you in the back who cared for COVID patients may not be aware of the impact Kelly had within the province of Ontario in the pandemic. It was Callie's modeling that allowed us to load level across the province and predict who was going to be there. She's one of these rare breeds who's trained not only in health policy, but health economics, and will at the end of all of this have more degrees than I've ever thought possible, but we'll deal with that. The other person behind her is, every once in a while, you meet a student who you just want to grab onto and keep forever, and she eventually will have to fly wings and spread. But Fatima Sheikh has been in my lab since the second year undergrad. Fatima is now completing her Ph.D., having completed undergrad work that I showed with you there, and a master's degree during the pandemic, and is now looking both from her research perspective, but within our hospital on equity, diversity, and inclusion, and its impact on sepsis. And so I will let them take the stage.
Thank you so much, Dr. Fox-Robichaud, and certainly to Biomaru for inviting us and really putting all of us in one room to catalyze on these conversations. So Dr. Barrett and I are going to spend the next few minutes talking a little bit about sepsis and really thinking upstream of the condition and really highlighting the importance of a Sepsis National Action Plan for Canada. You've probably heard this over the last few days over and over, but sepsis has been identified as a global health priority by the World Health Organization. So in 2017, there was the World Health Assembly Resolution 70.7, which really highlights the importance of building in clinical management of sepsis, diagnosis, prevention, and really establishing guidelines upfront given the severe burden of sepsis. And if I may be frank, due to a lack of action across member states, including Canada, in 2023, the Global Sepsis Alliance came together and put out the Berlin Declaration on Sepsis. And this was, a dire call to do more to reduce the burden of sepsis. And most recently here in 2024, just following World Sepsis Day in September, the Global Sepsis Alliance came back together again to put out the 2030 Global Sepsis Agenda, a strategy to alleviate the human, societal, healthcare, and economic burden of sepsis. And alongside that, we see the Pan-American Health Organization strategy and plan of action to decrease the burden of sepsis from 2025 to 2029. So not only is this, an issue here in Canada, but there have been global calls to address the burden of sepsis. Put simply, Canada has not met these goals. In 2019, CIHR did fund a research network, and you've been hearing a little bit about it today, Sepsis Canada, to study sepsis across the biomedical, clinical, health services, and population health pillars. And this has been a fantastic opportunity to develop much-needed research infrastructure. But Canada does not have a coordinated, proactive sepsis action plan. And so we continue to see causes of preventable morbidity and mortality. You've seen all of these statistics, 1 in 20 deaths in Canada, upwards of $1 billion in Ontario, more than 2 times the risk of falling into the top 5% and 1% of healthcare spending. And, Canada has this history of developing sepsis policies following tragic events. And one such example is the long-term care standards to prevent sepsis following the COVID-19 pandemic. Our team has recently done some work doing a jurisdictional policy review of sepsis policies, guidelines, and health professional standards here in Canada. And this is just a snapshot of some of our key findings. We weren't able to identify any provincial policies in the 3 territories, in Manitoba, Ontario, Quebec, or New Brunswick, highlighting a key policy gap. When we looked at the 66 Royal College specialties and subspecialties, only 10 of these included sepsis as a listed competency or objective of training, and often these were focused using narrow terms like pneumosepsis or urosepsis. And so Canada can and must do more, not only because we've identified the burden to our patients, their families, our healthcare system, and the global calls from the Global Sepsis Alliance, the World Health Organization, but because other countries have gone on to develop national action plans that have demonstrated success in reducing the morbidity and mortality associated with sepsis, and in fact, savings to the healthcare systems. And there are so many examples here on the screen, and this is only a snapshot of a few of them. I'll pass it to Dr. Barrett to speak a little bit about the work that we're doing and where we need your help.
Thanks, Fatima. So you've heard why we need a Sepsis National Action Plan in Canada, and in the absence of the development of one, we've decided we're going to start. So we're working with Dr. Tex Kissoon, who is the president of the Global Sepsis Alliance, and we are here at this conference to say, we need your help, we need to work together. What we need to do has been clearly laid out for us. We do not need to determine what we need to do. The Global Sepsis Alliance has done that, the Pan American Health Organization. We already know what work we need to do, we just need to start to do it. The GSA's 2030 agenda for sepsis identified 5 pillars that look very similar to the 5 pillars of the AMR strategy. We need to have political leadership and multilateral cooperation. We need governments to recognize that sepsis is an important health threat and recognize that all AMR deaths are in fact sepsis. So these are intertwined entities. We need to have support for a national sepsis action plan in Canada. We need to enhance and improve our health system readiness for sepsis and its sequelae. We need to have patient-focused clinical sepsis pathways that start in the community, including some of the work that you heard about in terms of antimicrobial resistance and antibiotic use in the community. We need to have optimized data collection and reporting. We need to be able to know who are our sepsis patients, where are they developing it, what pathogen is the cause, and how can we treat them best. And we heard from Minister Jones that there's a lot of work being done at Public Health Ontario, and that, I'm sorry, sounded very much like campaigning at a conference, but they could do more. They could certainly do more, and we'd really love to help them. We need to have a whole of society response. We need the public to understand that sepsis is a medical emergency, much like stroke and heart attack. Individuals need to be asking themselves, could this be sepsis? Do I need to speak to a healthcare provider? We need to be equity focused. You heard from Dr. Fox-Robichaud's work that Fatima has shown that individuals who are from marginalized communities are much more likely to experience sepsis and die from it. And my goodness, we saw that play out in the pandemic, didn't we? We need to truly support research infrastructure for sepsis in Canada. There needs to be dedicated funding to research. CIHR needs to prioritize sepsis research, and that is the only way that we're going to be able to support ongoing innovation. I sit on OTAC here in Ontario, and I'm completing a Ph.D. in health technology assessment, and I can tell you one of the big challenges is how do we support innovators who are doing amazing work? How do we support that work getting into the market? And some of that involves integrating yourself into a learning health system. We have the potential to do that in Canada. We just need to start. We have lots of great EHR platforms. We could be rolling these technologies out into the health system in a living health technology assessment, life cycle HTA perspective. We just need to start doing that. We need to have innovation in Canada for vaccines. I don't know if any of you in this room know, but there were attempts for homemade Canadian vaccines during COVID, and they couldn't get their clinical trials off the ground. And as we saw during COVID-19, we really need to appreciate that everything we saw during COVID-19, that respiratory failure that required people to be on ventilators and ECMO, that was a form of sepsis. So sepsis needs to be embedded into all of our pandemic planning for the future. We have already started this work in Canada, and Tex Kissoon has been helping to lead British Columbia. They're well ahead of us, so we need to work with these organizations that are already starting this work, collaborate, and spread these efforts across the country. So how do we think we need to do this? Well, it sounds a lot like what we've been doing for the AMR strategy. We need to have a scientific steering committee. We need to identify what we're going to do, how we're going to do it, have some working groups, start implementing programs, monitor the progress, and continually improve them. So why are we here? Well, I hope you now appreciate that sepsis and antimicrobial resistance are inherently linked. And as a clinician who treats patients with sepsis, I can tell you that without caution, there is significant potential harm. In my attempt to save my patients, I may be inappropriately using broad-spectrum antibiotics, but then as a consequence of antimicrobial resistance, my patients may die. And the WHO clearly states that sepsis national action plans must consider antimicrobial resistance. So I say to you all, they are linked. Please, we need to work together. We need your help. And we would really love to be able to leverage the opportunities to work together jointly and have a sepsis and an antimicrobial national action plan. And we're hoping that once we've got a little bit more work, we'll be able to come back and get some endorsement from these groups. Thank you. Stay tuned. This will be up and running shortly.